Thank you. Felicia Nall from Harvard University, the Global Task Force on Cancer Care and Control, and Mexico City's Tomatelo Pecho. It's a question for the WHO group and the work on cost effectiveness. Excellent presentation, Jeremy. Glad to be able to have seen the work now presented. To what extent are you or are we able to take into account the benefits and also the costs that aren't directly related to the health aspects? And given that we're talking about breast cancer, I know this is a topic that health economists have worked on for a long time, but all of the productivity losses, the family home losses, the losses in terms of childcare, given that we're speaking about a disease that attacks women and a lot of young women in developing countries, I think this is a particularly important aspect to underline. And in terms of our work over the next few days, I think it's especially important to highlight because I do believe that we should be also reaching out to the women in health community, to the broader community that's done so much on reproductive health and other issues related to women's health, and they will understand those numbers, I think, very well.
Well, let me first thank you for your very interesting comment. I fully agree. This is, of course, within the field of health economics, the question, what perspective do you take? Do you take only a clinical perspective where you only take into account the costs and effects within the clinical setting, or the social perspective where you take into account opportunity, costs, and loss of income because of diseases, the fact that once a mother is sick, she needs other people to look after her children, those kind of issues. To take those into account into this model, we have decided not to. Why not? Because it would make it very complex. Also, in a lot of low-income countries, how would you like to measure to quantify the income loss when a lot of people actually do not get a pay slip or a paycheck every month, those kind of issues. But of course, if you take those into account, it would be, I would be very much surprised if the cost effectiveness would be less favorable. Usually, taking those into account, of course, the outcomes are going to be more favorable for every intervention that you model. So yes, that it's an interesting comment, and policymakers as such should be aware and take those into account. Yes.
Can I just respond very briefly, just as a response to that? I understand completely as a health economist how difficult it is to add those in. I think it would be an interesting recommendation to the group to be able to think about it. It won't change your cost effectiveness results, except that it may change the age distribution of which you're recommending certain kinds of interventions, because it's going to really increase your effectiveness analysis, tremendously. It's going to go off the boards for women who are participating. And just say, because it's not easy, but if we turn to the labor economics literature and the gender disparities literature, we can find interesting ways to quantify the value of women's time, even if they're not working in a formal labor market and actually earning a wage. So I guess, Ben, a suggestion, an idea for the group would be to be able to see how can we do a little bit more in that area.
My question is to Dr. Perry Anyanwu from Nigeria. The first question is, since breast cancer in our environment is a premenopausal lesion, will it be cost effective to do ER/PR in patients in such an environment, since hormone therapy may not be the best way to handle those patients? The other question is, when we do FNAC, we very rarely get a result that says it's positive or negative. C3, suspicious, this and this. And many people are reluctant to offer cancer treatment when you have an uncertain disease. Especially when the patients will have to pay for the FNAC and the histology and the cytology, and also pay for the subsequent biopsy. We are just thinking that lesions that are below 3 centimeters, what is maybe better to excise them for histology, since even if it's a benign condition, the patient will not be happy so long as there are nothing will inform the patient that that lump there is benign. She will go to other areas to seek to seek for help?
Yes, regarding the ER positive negative question, this of course is an issue that touches upon the state of the healthcare system, where we will be doing this cost effectiveness analysis. For instance, in Costa Rica, being fairly developed, these kind of tests are being carried out by physicians standard. So those are, in Costa Rica, we will take into account the cost and the effects of doing an ER positive negative a test. When it comes, in Ghana, for instance, the situation is different. Not every patient is able to receive such a test just because the pathology services and etc. are not up to a level yet where those services can be provided for everyone. So we discussed this with surgeons in Ghana, and my colleague from Nijmegen University who is on the cost effectiveness project for Ghana. They decided to basically, in our study, prescribe tamoxifen to every patient, because the cost of tamoxifen is very low, and although of course it will only be effective in those people who are ER positive, the cost of doing a test, if someone is ER positive or negative, is very high compared to the cost of the medicine being prescribed. If someone seems not to react upon tamoxifen, then of course the change can be made to a different drug.
Stanley, you brought up a really interesting point that's already been brought up this morning, and that is pathology support. You know, I'm advocating doing core biopsies of certain things. Frankly, is there anybody to read the cores? Is there anybody to read the FNAs? Is it better, as you suggested, to excise the whole thing and it gets shipped someplace else? Again, it's one of the issues as we try and raise the bar here, that the pathology support really goes hand in glove with the other things we're trying to work on as well.
There will be some discussion of that this afternoon at the Ghana session, and work that Britt Marie Young has done in our training courses that's relevant.
So 2 points. One, with respect to the ER issue and the comment that just give tamoxifen, it's cheaper than doing the test. I saw in Colombia it costs $25 to test for ER, PR. I would argue you don't need to test for PR probably. And I can't imagine that 5 years of tamoxifen taken daily could cost less than $25, and the complications, even if they're rare, of endometrial cancer and venous thromboembolism, you just get a couple of those per 100 patients, and that's got to drive up your cost. So it's all how you value and place it. But what I was really going to say, yeah.
It's not only the cost in this specific point, but it's also that the value of the hormone receptors is important for having a treatment of the patient. I mean, there are patients whose hormone receptors are one of the main arguments for making or not a treatment. So I don't think it is possible to just don't do it, and that's a good...
I agree. Yep, but very quickly, we're finishing. What I was going to mainly mention was the HER2 testing, which was also brought up in the same context. And if you don't have access to HER2 targeted drugs, it doesn't make sense to test. But all the modeling for cost effectiveness has been done with 1 year of treatment, and that makes it ridiculously expensive. We have a finished trial showing 9 weeks offers benefit, and we've never done trials of 52 weeks versus 9 weeks because it doesn't benefit the pharmaceutical company. And so we as a group have to be pushing for studies where, especially with all these new biologics that are very expensive, what is the optimal duration of treatment? Because your modeling would be very different with 9 weeks of treatment.
Thank you very much. I'm sorry we can't.
But so we have, I'd like to do that question one more time. This is the same question as before regarding hormone receptor testing. Everyone can grab their little device. A is largely unavailable in low-resource scenarios. B has little relevance in low-resource settings, or both.
No, you can only
Okay. Interesting. Okay, we'll have to compare that with earlier.